Today we're going to see the topic malaria. Blood protozoa mainly is genera trypanosoma. The most important blood protozoa are T. brucei among the trypanosoma, rhodescens and cruzi. By speaking about the leishmania, this causes the leishmaniasis disease, L. donovani, L. tropioca, L. brasiliensis. And the third one is the plasmodium. The types of Plasmodium falciparum, vivax, ovale and malaria. The subphylum Epicomplexa. This is a Plasmodium species. While speaking about the etiology, there are 4 Plasmodium species that are responsible for the humane malaria. These are Plasmodium falciparum, vivax, ovale and malariae. The term malaria was derived from the Latin word malaria or the bad air, denoting the disease association with the bad smelling. That is the air coming from the stagnant water. The breeding site of the mosquitoes that harbored the malaria parasite in the olden times. Malaria, this is the disease of the antiquity. It is caused by the protozoan parasite of the genus Plasmodium, which is transmitted to the man when the parasite's infective stages are inoculated by the mosquito during the blood meal. There are 4 species of the Plasmodium which infect the man. Each species produces a distinct infection with the colloquial name. Plasmodium malariae, found by Leveran in 1881, causing the intermittent fever every 72 hours of the quartan malaria. Plasmodium vivax, found by Grassi and Felletti in 1890, causing the intermittent fever every 48 hours of benign latent malaria. Plasmodium falciparum, caused by this causing the intermittent fever every 36 to 48 hours. This was found by Welch. This is a malignant tertiary malaria. Quotidian or every fever is caused by asynchronous release of the merocytes in the circulation. The fourth one is the Plasmodium ovale, found by Stephen in 1922, causing the intermittent fever every 48 hours or ovale tertiary malaria. The normal cell will be with the regular RBC, while the infected RBC with the accumulation of the yellow granules. This is a malaria parasite that multiply in the RBC. While speaking about the epidemiology, there are an estimated 200 million global cases of malaria, leading the mortality of more than 1 million people per year. The Plasmodium falciparum, malignant tertiary malaria, and the Plasmodium malaria, quartan malaria, they are the most common species of the malaria parasite and are found in the Asia and Africa. The P. vivax, that is a benign tertiary malaria, predominates in the Latin America, India and Pakistan. Whereas the P. ovale, ovale tertiary malaria, this is almost exclusively found in the Africa. Malaria parasite trophocyte. They are generally ring-shaped, 1 to 2 microns in size, although the other forms, amoeboid and band, may also exist. The sexual forms of the parasite gametocytes are much larger and 7 to 14 microns in size. The falciparum, this is the largest and is the banana-shaped, while others are smaller and round. Vivax causes the stippling of the infected red cells. Thin blood smear, thick blood smear. Here we can see the falciparum, malariae, ovale and vivax. This is the microscopic feature of the falciparum in the ring stage. Plasmodium malariae in ring stage. This is the applic form, ring with the double chromatin dot. And the older ring stage of the parasite, doubly infected erythrocyte, multiple infection, 6 rings into erythrocyte. Plasmodium malariae. All the sexual stages of the parasite may be observed in the peripheral blood. The infected RBC are normal in size. In the trophocyte stage, the young ring forms are about 1/3 of the diameter of the RBC and have a peculiarly solid appearance. The developing trophocyte lacks a vacuole. This is band-like in form and the pigment granules are large and numerous and dark. There are 8 merocytes in the schizoid stage. These merocytes are usually arranged peripherally around the centrally clumped pigment in the rosette formation. The gametocytes, they are spherical or oval in the normal sized RBC. These are abundant, prominent dark brown coarse pigments scattered inside the RBC. Plasmodium vivax. All the asexual stages are also seen in the peripheral blood. The infected RBC are enlarged and decolorized. The sphagnum dots are prominent. The ring form or the young trophocyte occupies the one-third of the diameter of the RBC and usually has one chromatin dot. The rings are definite but the outlines are irregular. The developing and old trophocytes are larger with very irregular pseudopodial process of the cytoplasm. The schizoid usually contains 8 to 24 merocytes. Gametocytes are spherical or ovoidal in shape. It enlarges the RBC. The scarcenous dots are also prominent in these stages. Plasmodium falciparum. The infected RBC are not enlarged or discolored. The multiple infection of the RBC is common. Plasmodium falciparum. The infected RBC are not enlarged or discolored. Multiple infection of the RBC is common. Normally, only the ring forms or the young trophocytes and the gametocytes are observed in the peripheral blood. The ring form as a delicate thread-like line of cytoplasm measuring about 1/16 of the RBC. Some ring forms have the double chromatin dots. Others are found in the margin of the RBC and are called applic or the école forms. Characteristically, the red cells may be invaded by the several rings even up to 8. Schizoids are usually not found in the peripheral blood. When seen, the merocytes usually number 8 to 32. The gametocytes seen in the peripheral blood are crescent or the sausage shaped. The gametocytes appear in the peripheral circulation 8 to 11 days after the patency that disappear after about 3 months. Plasmodium malaria, the infected RBC is the Plasmodium ovale. The infected RBC is somewhat larger than the normal, oval in shape and usually with the fringed or the irregular edge. The scarcenous dots appear very early even in the older rings. All the stages are found in the peripheral blood. The trophocytes comprise a single bead of chromatin connected by the ring of cytoplasm surrounding the vacuole. Merocytes, which are 4 to 8 in number, may be arranged in the rosette formation around a mass of blown pigment granules. They are rather larger, round or oval bodies and occupy the whole of the enlarged infected RBC. The LC essentially involves two phases: the asexual phase in the intermediate host, which is man, the sexual phase in the definitive host, which is the female Anopheles mosquito. Asexual phase in the man, the pre-erythrocytic schizogony. The cycles begin with the inoculation of the infective sporocytes to man during the mosquito blood meal. Within half an hour, they are carried with the blood circulation into the liver parenchymal cell, which they invade and where they undergo the nuclear and the cytoplasmic division, schizogony, and give rise to the merocytes. These merocytes invade the RBC. Exoerythrocytic schizogony. In Plasmodium vivax and ovale, the sporocytes develop into the hypnocytes, which remain dormant in the hepatocytes. At the predetermined time, the hypnocytes begin to grow and undergo the exoerythrocytic schizogony. The merocytes are released and they invade the RBC, causing the recurrence of the malaria attack all the time relapse. The Plasmodium falciparum and the P. malariae, the sporocytes do not develop into the hypnocytes, but they directly become the pre-erythrocytic schizones, producing the merocytes. Erythrocytic schizogony. The merocytes formed in the pre-erythrocytic cycle are released into the bloodstream and enter the RBC through the erythrocytic surface receptor and start the erythrocytic schizogony. This release of the merocytes, including the RBC and the parasite membrane and the metabolites called the pyrogens, causes the typical intermittent chill, fever and sweating which characterize the malaria paroxysms. On the other hand, this may also result from the release of the cytokines, TNF and the caecin from the macrophage at the time of schizoid rupture. The IP in the malaria is the interval between the inoculation of the sporocytes to the release of the merocyte of the erythrocytic schizones. On the average, the IP for the 4 species of Plasmodium falciparum 12 days, Plasmodium vivax 13 to 17 days. Plasmodium p ovale 13 to 16 days. Malaria 28 to 30 days. Gametogony. Some of the merocytes released from the RBC do not undergo schizogony nor infect the more RBC, but they develop into the male and the female gametocytes which are infected to the mosquito. Sexual phase in the mosquito. Sporogony. The male gametocytes occur in the mosquito during the blood male undergo the maturation and differentiate into the microgamete and the macrogamete. The microgamete exflagellates and fertilizes the macrogamete, producing the zygote. The later develops into the oocyst, which undergo the cell division, sporogony, giving rise to many sporocytes, which is in the infective stage to man. When an infective anopheles bites the man, the sporocytes from its salivary gland are inoculated through the skin into the circulation. Malaria parasites are transmitted by the infected female Anopheles mosquito, in which they inject the sporocyte present in the saliva of the insect sporocyte that infects the liver parenchymal cell, where they may remain dormant. Hypnocytes or undergo the stages of schizogony to produce the schizons and merogony to produce the merocytes. When the parenchymal cells rupture, thousands of the merons are released into the blood and infect the red cells P. ovale and P. vivax. They infect the immature red blood cell, whereas the P. malariae infects the mature red cells and the falciparum infects both. In the red cells, the parasites mature into the tropocytes. These tropocytes undergo the schizogony and the merogony in the red cells, which ultimately burst and release the daughter merocytes. Some of the merocytes transform into the male and the female gametocyte, while others enter the red cell to continue the erythrocytic cycle. The gametocytes are ingested by the female mosquito. The female gametocytes transforms into the ookinete. This is fertilized and forms an oocyte in the gut. The oocyte produces the sporocyte, sporogony, which migrate to the salivary gland and are ready to infect the another host. The liver extra erythrocytic cycle takes 5 to 15 days, whereas the erythrocytic cycle takes just 48 hours to 72 hours. Malaria can be transmitted by the transfusion and transplacentally. The symptomatology of the malaria depends on the parasitemia, the presence of the organism in the different organs, and the parasitic burden. The incubation period varies generally between the 10 to 13 days. As the parasite load becomes significant, the patient develops a headache, lassitude, weight pain in the bone and the joints, chilly sensation, and the fever. As the disease progresses, the chills and fever become more prominent. The chill and fever follow the cyclic pattern, with the symptomatic period lasting 8 to 12 hours. In between the symptomatic period, there is a period of the relative normalcy, the duration of which depends upon the species of the infecting parasite. This interval is about 34 to 36 hours in the case of P. vivax and P. ovale, and 58 to 60 hours in the case of the P. malariae. A classical tertian paroxysm is rarely seen in the P. falciparum, and persistent spiking or a daily paroxysm is more usual. The malaria paroxysm is most dramatic and frightening. It begins with a chilly sensation that progresses to the teeth chattering, overtly shaking chill, and the peripheral vasoconstriction, resulting in the synoptic lips and nails. That is in the cold stage. This lasts for about an hour. At the end of this period, the body temperature begins to climb and reaches the 103 to 106 degree Fahrenheit. The fever is associated with the severe headache, nausea, vomiting, and convulsion. The patient experiences euphoria and profuse perspiration, and the temperature begins to drop. Within a few hours, the patient feels exhausted, but the symptom lists and remains asymptomatic until the next paroxysm reaches the entire zone. Each paroxysm is due to the rupture of the infected erythrocyte and the release of parasites. Without the treatment, all species of the human malaria may ultimately result in the spontaneous cure, except falciparum, which become more severe progressively and results in death. This organism causes the sequestration of the capillary vasculature in the brain, gastrointestinal tract, and the renal tissue. The chronic malaria results in the splenomegaly, hepatomegaly, and the nephritic syndrome. Symptoms of the malaria are due to the release of the massive number of the merocytes into the circulation. Infection results in the production of the antibodies, which are effective in containing the parasitic load. These antibodies are against the merocyte and the schizons. The infection also results in the activation of the reticular endothelial system. The activated macrophage helps in the destruction of the infected erythrocyte and the antibody-coated merocyte. The cell-mediated immunity also may develop and help in the elimination of the infected erythrocyte. The malarial infection is associated with the immunosuppression. Diagnosis. This is based on the symptoms and the detection of the parasite in the KIMSA stained blood smear. There are also the antibody tests. The lab DX is based on the demonstration of the malarial parasite either in the peripheral blood using the thick or thin blood smear taken during the febrile state and stained with the field KIMSA or the white stain, or in the bone marrow through the sternal aspirator. The QBC method, quantitative Buffy coat, which utilizes acridine orange staining technique and the fluorescent microscopy, have been developed to improve the sensitivity of the microscopy. Serological tests for the detection of the malaria antibodies have been developed. These are the indirect fluorescent antibody test, indirect hemo-agglutination test, and gel diffusion test, and ELISA. They are used to complement the microscopic DX and not to replace the latter. Moreover, the clinical DX is based on the clinical HX, and course of the DSC should always be the mainstay in the malarial diagnosis. The dipstick test, parasite test for the rapid DX of the falciparum malaria has been developed. The dipstick for the P5X is still currently being developed. This test is an antigen capture test which detects a tropocyte-derived histidine-rich protein H. Its reliability is currently being tested in the several field trials in the endemic countries. Malaria is endemic predominantly in the tropical and the subtropical countries. In the Philippines, 68 out of total 77 provinces are endemic. 3 places like Cebu, Bohol, and the Catanduanes, they are already the malaria free, while 6 others may be freed from the malaria soon. The principal mosquito vector, Anopheles flavistrus, breathes in slow flowing, partly shaded, clean mountain stream. There are 3 secondary vectors, Anopheles mangianus, which is a clean stream breeder, Anopheles balabensis, which is a forest swamp pool breeder, Anopheles litoriasis, which thrives in the blackish water, Anopheles maculoides, they are also the stream breeder in the potential vector. The annual parasite incidence is 5.5 by 1000, with 71.12% of cases caused by the falciparum, 28.03% of cases caused by P5X, and remaining 0.82% of mixed infection. The transmission is perennial with 2 peaks, one at the beginning and the other at the end of the rainy season. P. malaria occurs in the 0.03% of cases. 2 indigenous cases of the P. ovale infections were reported from the Palawan Island in 1967. Malaria can also be transmitted through the blood transfusion by the congenital infection and the contaminated needle, especially among drug users. In these cases, the exoerythrocytic phase in the liver is absent. Treatment is effective in the various quinine derivatives, quinine sulfate, chloroquine, mefacquine, and the primaquine. Drug resistance, particularly in the falciparum and to some extent in the 5X, is a major problem. Control measures are the eradication of the infected Anopheles mosquitoes. Vaccines are being developed and tried, but none is available yet for the routine use. Chloroquine is the DOC for the TX of the suspected or the confirmed malaria in the areas where there is a little or no parasitic resistance of this drug. It is given at the dose of 10 mg per kg once a day for 2 days, then 5 mg per kg single dose on the 3rd day. Sulfadoxine, pyrimethamine combination of the quinine may be used where there is a high level of resistance to chloroquine. In areas where there is a resistance to the earlier mentioned drugs, mefloquine or sulfadoxine, pyrimethamine, the combination may be used. Primaquine is the only drug currently available for the radical TX of the relapsing vivax of the ovale malariae. Chemoprophylaxis is widely believed to provide the best protection against malaria pending the availability of a vaccine. But the emergence of a drug resistance, the potential toxicity of the prophylactic drugs do not warrant its use in all circumstances. And so the screening of house and the use of the mosquito nets, especially insecticides, impregnated nets, protective clothing and insect repellents can still be relied upon in the limiting the risk of malaria. Vector control with the chemical insecticides and the larvicides, larvivorous fish and other biological control agents, the environmental measures aimed at eliminating the mosquito breeding sites. It's theoretically the most effective way of controlling the malaria in the long term. but the effective application of such measures has been complicated by the high cost of the insecticide as well as the emergence of a mosquito resistance to insecticide. On the other hand, the malaria control as a part of the primary health care must be focused on the reliable and prompt diagnosis as well as the adequate MGT. Thank you.